All right, everyone. So welcome to my presentation. This is just a personalized tapering of an antidepressant and deprescribing journey of a patient. So let's dive right in. So our patient is a 21-year-old female student. She does live independently. Her medical history, she was diagnosed with generalized anxiety disorder in January of 2020, and also a diagnosis of irritable bowel syndrome in 2021 with intermittent symptoms. In terms of her medication history, since June 2019, she was initially prescribed fluoxetine 20 milligram once daily after a visit to the hospital due to suicide ideation and severe anxiety. In November of 2019, that was then switched over to desvenlafaxine 50 milligram by her family physician. And as of September 2023, during a refill, I had a consultation with the patient and we discussed some elements of her therapy, such as goals of medication therapy and the duration of therapy. Initial medication list, she was prescribed desvenlafaxine 50 milligram, which was started in November of 2019 for her anxiety. She did notice significant improvements initially in her symptoms, but then that was shortly accompanied with adverse effects such as mental fog, which manifested in difficulty concentrating, having severe sedation at times, and also some emotional blunting with use. One of the other side effects that our patient was complaining about was significant abdominal discomfort and pain, especially after taking each capsule every single day. And around 2023 September, she did experiment with beginning to reduce her dose on her own, experimenting with every other day dosing. Some of the OTC items that she was taking were vitamin D and also magnesium bisglycinate. So some of the initial issues that I brought up as a pharmacist, I was concerned with some of the long-term adverse effects from the desvenlafaxine, also the potential for some of a little bit of tolerance, or also known as antidepressant tachyphylaxis, or colloquially known as antidepressant poop out, where the medication can begin to lose its efficacy over time. And that's one thing that the patient was beginning to display in terms of how she noticed that her symptoms were still kind of present with her anxiety. I was also interested in, like I said, reviewing her initial goals of medication therapy and seeing that if she had accomplished those goals, if it was a good time to consider coming off the medication. The patient's main concerns was that she didn't want to be on antidepressants for the rest of her life. She was concerned with some of the long-term adverse effects and some of the difficulties that may arise when stopping the antidepressant, along with the significant upset stomach that she was experiencing. And she was ready to begin sort of approaching her mental health using a more holistic approach. So in terms of her deprescribing journey, she was referred to me in September of 2023 by her psychologist. She did appear to be a good candidate for deprescribing, and she was highly motivated to explore alternatives to help sort of treat her anxiety with non-pharmacological interventions. Following her kind of interventions that I helped kind of introduce into her life and into her mental health toolkit, such as mindfulness-based stress reduction and meditation, breathing techniques for relaxation, and also physical exercise for stress reduction and overall health. Of course, she was also receiving cognitive behavioral therapy from her psychologist, and using this as a sort of strong mental health toolkit, she was kind of ready to begin her journey tapering off her medication. So the deprescribing plan that I created for her. So as some of you may know, desvenlafaxine is an antidepressant that is commercially available only in 50 and 100 milligram tablets. But however, because I work in a compounding pharmacy, we were able to facilitate the taper using a compounding liquid solution. And we chose a hyperbolic taper approach, which if you're interested in learning more about, I'd highly recommend you check out the webinar from last month with Dr. Mark Horowitz, where he dives into the ins and outs of hyperbolic tapering and its implications in deprescribing of antidepressants. But essentially, with hyperbolic tapering, the goal is to reduce the medication by a theoretical 10% reduction in serotonin receptor occupancy. And the way that I was able to calculate sort of my serotonin receptor occupancies for this specific taper plan was pharmacokinetic parameters and Michaelis-Menten equations in a computer model calculator online. So based on the taper plan, you can see her baseline dose of 50 milligram gave about a 91% sertraline receptor occupancy. And there's 8 phases in the taper plan, so ranging from 25 milligrams all the way down to 0.75 milligrams. And like I said, the goal is to reduce the dose by a 10% reduction in the serotonin receptor occupancy. A little note about antidepressant withdrawal symptoms. It's important that when a patient kind of goes on this process of tapering and deprescribing off an antidepressant, that we have a conversation about withdrawal. So that's one thing that I really coached and emphasized with my patient, making sure that she was aware of potential withdrawal symptoms that can occur, especially once we begin the taper process. And during each phase of the dose reduction, it's important to be able to distinguish whether we're having a relapse or whether we're having a withdrawal, and making sure that you have strategies in place to what I like to say, help ride the wave of withdrawal. And that's one of the ways that we can kind of distinguish the difference between relapse and withdrawal, is that withdrawal typically presents in a wave-like fashion. You have the onset of the withdrawal, you have its peak, and then it kind of dissipates as time moves on. And a lot of the techniques that we use to help our patient sort of ride that wave of antidepressant withdrawal are kind of the things that I mentioned earlier: mindfulness-based stress reduction, breathing techniques, of course, CBT, and physical exercise. We also added on potential medications to manage certain physical symptoms of withdrawal, for example, ondansetron for nausea and vomiting, and beta-histine for vertigo and dizziness. So this is a brief video explaining the patient's experience with hyperbolic tapering.
So first question, what motivated you to stop taking the medication?
I became really motivated to kind of stop my medication, as I realized throughout the years that I was very dependent on it, and it's not something I very much enjoyed. I also knew I wanted to start tackling my anxiety and depression in a much more holistic manner. I take my diet and also exercise very seriously in my life, so I wanted to use those tools a lot more to help me out with my anxiety and depression. The medicine was extremely helpful when I first took it, as I did have really horrible suicidal thoughts and my anxiety was all over the place. So it was definitely a very helpful tool at the time.
Did you ever experience any adverse effects from the medicine? And did you ever try stopping this effects abruptly on your own?
Oh, definitely. I had really terrible stomach issues for the past few years, and I also noticed every time I would miss a dose or even go a few hours with it, I would get extremely dizzy and nauseous, and that kind of showed me how reliant I was on the medication and motivated me even more to go off of it. I did try tapering it myself, and I do not recommend this. I would go sometimes a day or two without taking the medication. I cut them up at some point, and it did not work at all, and it was just a roller coaster of emotions.
Last question. During the hyperbolic tapering phase, how would you describe how it's felt? How can you tell whether any emotional changes are related to withdrawal rather than other factors?
Well, the whole process has been a really wonderful learning experience, but it definitely has been difficult. The worst scenario or moment I can remember was back in November when I did one of my big first taperings, and I had a really bad withdrawal episode. I felt extremely suicidal, which I haven't had in years. And this was at a point in my life where everything was really stable: my relationships, school, I was eating well, exercising. It was 3 to 5 days after I tapered off. So I kind of had an idea that it was due to medication. I also had really bad physical symptoms. I got really dizzy, nauseous. Once again, all those withdrawal symptoms I would feel whenever I skipped a dose or missed it by a few hours, but enhanced 10 times. But other than that, the past 6 months have really been great. To be honest, I've learned a lot more what tools I really need in order to do the tapering in a much more smooth manner, and also just really taking my time with it and not trying to rush the process.
So just a rough summary of her experience from September 2023 to, as of now, June 2024. So baseline, again, 50 milligrams daily with desvenlafaxine, and we started phase 1 in October of 2023. It was 25 milligram once daily for 4 weeks. And then in phase 2, which began in November of 2023, we had dropped the dose down to 15 milligram, but 5 days after reducing the dose, she did experience that significant episode of withdrawal. And that manifested with really intense emotional symptoms, as the patient had mentioned in the video, such as sadness, tearfulness, anxiety, and dread. But luckily, relying on our mental health toolkit, we were able to help kind of get her through that process and overcome some of the emotional symptoms of withdrawal that she was experiencing. And we're happy that it was able to resolve in actually 48 hours. So although it was an intense 48 hours of a withdrawal episode, the patient was able to come on the other side of it. And we decided at that point to hold the medication at that dose and not progress further with the taper, just because the patient was a student at the time as well. She had exams coming up, and we didn't want to put any of her academic sort of year in sort of any how can I say, we didn't want to jeopardize any of her exams or anything like that. So we decided to put the taper on hold until March of 2024, where we began phase 3 at 9 milligram once a day. And that was successful. And we stayed on that course for 6 weeks before going down to phase 4, which began in April at 6 milligrams a day. And currently she's at phase 5 at 4 milligrams daily, and she's progressing really well. And we're anticipating completing the taper by about October of 2024. She still has 3 phases still left to go at 2.5, 1.5, and then 0.75. So the final medication list that she's currently on. So currently, she, like I said, she's on phase 5 of the taper at desvenlafaxine 4 milligram daily. And she's very confident that she can complete the course over the next 3 months. And we're currently projecting to taper at a 4-week interval currently. So anticipated completion will be in October, and the current duration of the taper thus far has been about 9 months. In addition to the physical symptoms of withdrawal that she experiences sort of on an ongoing basis, we have beta histine 16 milligrams, which is used as needed, and ondansetron 4 milligrams, which is also used as needed. So some of the core lessons from this case, what I specifically learned as a pharmacist and clinician is that hyperbolic tapering definitely has to be individualized and tailored to the patient's unique circumstances. Before, when I outlined the taper plan, we kind of had decided, the patient and I were on mutual page to go at a 4 to 6 week interval in terms of our phase reductions. But of course, once we had that initial episode of withdrawal that manifested during the 3rd phase, we decided to kind of pump the brakes and say, we'll keep the dose at as is at desvenlafaxine 9 milligram until or 15 milligram until the patient could stabilize further. And you really have to fit the taper to the patient's unique circumstances. As I mentioned, the patient was in school at the time, and we didn't want to interfere with any of her academic progress in her exams. So tailoring the taper plan to the patient is very important. And it made me understand that, with deprescribing and tapering is specifically for antidepressants, it's a very dynamic approach. Things won't always go according to plan. However, if you do have the right tools in place, withdrawal symptoms can definitely be overcome. And it's all about making sure we have the right support measures in place for the patient. And what she specifically learned was that she does have some agency and control over her mental health. And she feels like she's in a much better place now with having other tools that she can rely on to help sort of overcome any obstacles or issues or stresses that she feels with mental health. And although we're not 100% done to taper yet, the patient is in really good spirits, and she's very motivated to move on this journey. And that concludes my presentation. Thank you so much for listening, everyone. Happy to answer any questions.
Thank you very much, Shawn. Beautiful presentation. Thank you for staying on time. There are quite a few questions, and they're grouped into about 3 parts. I'm going to start with a simple pharmacokinetic one first. From Holland, Dr. Dinkelberg, was this woman taking desvenlafaxine extended release?
Yes.
She points out that if you were tapering using a liquid formulation, one would no longer have the extended release pharmacokinetics. And does that make it more likely that you get interdose withdrawal? And maybe I could elaborate. Should you then, if you're trying to prevent that, should you divide the dose into 2 times a day or even 3 times a day?
That's an excellent question. Thank you, Pauline, for that. So I worked with our compounding pharmacist to kind of create the solution accordingly. Because desvenlafaxine is not sourced in USP grade powder, we actually had to work with a tablet. So we were able to add some ancillary agents to kind of mimic the extended release of the desvenlafaxine tablet. So thus the patient, and that was one of our kind of one of the things I had in my back pocket, thinking when we started the taper process, in case she did experience any sort of withdrawal right away, that's something that we could have tweaked and worked with. But luckily, none of that wasn't really an issue that we came up across. But that is an excellent point. When you're working with extended release formulations, whether it's desvenlafaxine or Effexor, it can be difficult sort of formulating that compound. And that's why it's important to have a good team at your compounding pharmacy. Luckily, which I'm not the expert at, but I do rely on a great team of technicians and pharmacists that were able to kind of play around with different formulations.
There's a relevant question from Dr. Barb Farrell in Ottawa, which is, can you estimate the cost of doing a taper in this way? And is there any way for patients to have that covered, or do they have to pay out of pocket? in Canada, I guess you can speak to only.
Excellent question. So the compound is covered by all insurances. That's one of the beauties of compounding, at least here in Canada and in Ontario, where I'm based out of. But anticipated cost, it depends on the compounding pharmacy. Of course, it depends on the fee that they set out, which depending on where you go and location, it can differ. And it also depends on the stability of the compound. So typically when you get a medication in tablet form, you can fill up to 3 months covered by insurance. But because some compounds have different stability, some are 2 weeks, some are 4 weeks, that impacts the rate of dispensing as well. But in my experience, along with the patient as well, although at my pharmacy, we don't directly bill to insurance, we do provide official receipts and also letters to the insurance as well. And thus far, so in my journey, at least compounding different formulations of different antidepressants, there have never been really any issues with getting reimbursement. It's just some pharmacies are set up to bill directly, some prefer not to.
Shawn, there were a number of questions about fluoxetine. One question was, do you know why this patient stopped fluoxetine and was she tapered? Another question is, in some, one questioner notes in some younger patients, they complain that fluoxetine made them quote unquote too energetic. Is that unusual? And how should one manage it if a person is too energetic? For older people like me, that's hard to imagine in young people, but I hope no one takes offense at that.
Well, is there another part to that question, Tom, or that's
fine? That's well, there's also some discussion in the chat about whether the long elimination half-life of fluoxetine and its active metabolite norfluoxetine in fact protects people from withdrawal. I think if the audience is really interested in that, and if Dr. Gill and Dr. Mark Horowitz, who's posed a comment about that, are willing, we might be able to carry on a few minutes extra after the second case. And I'll ask then if people are interested, if either of you are able to participate in that.
So to answer the first part of the question, when the patient was initially switched over, it was, I believe, due to lack of efficacy. And her family doctor then decided to put her on desvenlafaxine. At that time, she had been on the fluoxetine for a few months, but I think she was still having severe symptoms of anxiety and dread. So that kind of initiated the family. That was kind of the impetus for the family doctor to decide to switch over to desvenlafaxine. To answer the question about the taper for fluoxetine, I haven't yet had a patient where I've had an opportunity to build a taper plan for fluoxetine. I'm excited about the prospects, but there's I know I think I haven't checked the chapter in Mark Horowitz's Maudsley Deprescribing guidelines on fluoxetine, but I think there is an approach for a hyperbolic taper available. And although we do know that the half-life of fluoxetine is significant, it can be multiple days, theoretically can protect against some of the withdrawal. But reading on fluoxetine, I had one patient I was potentially thinking about tapering off. There's some sort of anecdotal data that suggests that because of the long half-life, some of the times the onset of withdrawal can be delayed significantly. So that's one thing you have to kind of have on your radar with a fluoxetine taper, because even although the medication is, the half-life is so significant and long, withdrawal may present later on in the taper process as opposed to imminently after reducing a dose with a shorter half-life agent. So I think that's one thing to always keep on your radar with fluoxetine, but I can't speak much to it because I don't have any experience yet tapering a patient off fluoxetine, but highly interested in that opportunity if that arises.
Shawn, there's another comment in the chat. I don't think it requires an answer. It's not a question, more of a comment that looks to me like a pharmacist is pointing out that one difficulty with tapering regimes is persuading a prescriber to write a different prescription other than the standard.
It can be difficult, of course, but that's why it kind of puts us in the light as pharmacists to really flex our muscles clinically and build clinical relationships with our other community clinicians to help focus on tapering patients in the right way. And I will say this as well, Tom, to the rest of the audience, in my experience, like I've had a lot of success stories with patients where they do a linear taper as well. So some doctors, they may have more experience with linear tapers, of course, and they may have seen a lot of success stories, but in my experience as a pharmacist so far, it's really about presenting the evidence and presenting the data and presenting the plan and getting the doctor on board. And if they're not on board, if the patient goes through the linear taper and they happen to fail, or they experience significant withdrawal, it allows us to kind of go back to the drawing board and then present it again. So I'm always excited about the prospect of meeting new clinicians in my area that are sort of passionate about deprescribing and also interested in sort of the field of hyperbolic tapering, because it presents us opportunities to kind of build more clinical relationships. So to any pharmacists out there, I would just encourage you to keep trying. It's, like I said, the story of my life so far. And sometimes you have success, sometimes you don't, but that's just part of the game, I guess.
Dr. Gill, thank you very much. There are a number of other questions, and I will, when we finish the second case, I will invite you and anyone in the audience, if you want to stay for another 10 or 15 minutes, if it's possible for you, we might be able to come back to some other questions or some discussion. But thank you again. I'm now going to introduce, we'll switch over to Dr. Marrison Marwood and Dr. Shayna Henry of McMaster University Department of Family Practice. They have a exceptionally complicated case. If you thought Shawn's was hard, wait till you see this. Over to you.
Perfect. Okay, good afternoon, everyone. Thank you for having us. Dr. Henry and I worked together in a large academic teaching practice where she was my preceptor during my family medicine training. We hope today to describe the deprescribing work we did with a patient who had concerns about a tremor, his sleep, cognition, and low mood in the context of really significant medical complexity.
So as the new MRP in this practice, having recently taken over the practice from the previous family doctor, I was trying to get familiar with some of the more complicated patients in the practice. So as you can see, this 62-year-old patient had several medical diagnoses listed in his chart. He also had many issues that were being actively investigated and many specialists involved in his care. So it was quite difficult to get a sense of how some of these diagnoses, particularly the psychiatric diagnoses, had come about, because there were quite a lot of missing consult notes. So overall, we felt we needed to dedicate some time to better understand his medical history, what had been done already, and really kind of clean up his chart to see where to go from here and make sure we were using up-to-date information. So we don't want you to look at this slide and feel overwhelmed. We don't expect you to absorb all of this, but we just wanted to convey a sense of the complexity and the context in which we met this patient.
So the patient was first booked in with me for a standard 10-minute appointment, and the reason was listed as needs referral. He said to me that his long-term psychiatrist had retired about 2 years previously, and he felt that his mood had significantly worsened since then. And then he handed me this list of concerns. So as you can see, this is a scanned copy of his list. It raises a lot of safety concerns, both from a physical perspective and a mental health perspective. It was also really overwhelming to try to address this and triage these concerns in such a short appointment. I glanced at his medication list. We will come back to this in detail, but his med list was clearly out of date. It had duplicates, old medications, and it was clear that multiple prescribers were involved. This raised a lot of concerns for us about polypharmacy and the possibility that some of his concerns may be related to drug-drug interactions or side effects. One of the first things we did was dedicate time to get an accurate, up-to-date medication list. The patient had been recently hospitalized with considerable weight loss and complications on Ozempic. So as you can see, the pharmacists in our clinic had already done some amazing work with deprescribing his multiple diabetes medications. So those had already been stopped. After our medication reconciliation, though, I still was concerned about the possibility of prescribing cascades. I was concerned with how to address his depression in the context of these multiple psychiatric medications, and I wondered about the use of opposing medications. So in particular, the patient was on 2 antipsychotics, but also on levodopa.
So he was seeing specialists, particularly regarding his urinary and GI complaints. So Dr. Marwood and I decided to focus on the 4 main areas of concern identified by the patient. So that was movement and tremor, sleep disturbance, cognition, and mood.
So starting with the tremor, the patient described a 10-year history of resting and action tremors, which you'll see in the upcoming video. He also described tripping over his feet, having had multiple falls. I wondered about bradykinesia because his family said that he could not keep up with them anymore. And I also wondered about mass facies or limited facial expressions. In addition to these signs of Parkinsonism, I also wondered if some of his other symptoms could be non-motor features of Parkinson's. On chart review, I found that he had presented many times initially with just an action tremor, so it was thought to be an essential tremor. Over time, though, he developed these other motor symptoms. He was diagnosed with restless leg syndrome by his psychiatrist and started on pramipexole. And earlier in 2022, his previous family physician, suspecting Parkinson's disease, had stopped the pramipexole and started him on the levodopa carbidopa while awaiting a specialist neurological consult, which unfortunately in our region has a 2-year wait list. So that was the initial video that the patient brought in.
September.
As you can see, he had both a resting and an action tremor, but he didn't have significant loss of amplitude on most of the repetitive movements. He did have very poorly coordinated hand movements. On the other hand, his sit to stand and his gait were fairly normal.
So the next issue that was really important for him to address was poor sleep, which was regularly raised by him, and particularly he was having trouble with sleep onset and daytime fatigue. When we looked at his chart, we felt that there were several possible contributing factors. From a medication perspective, we wondered whether the long-acting methylphenidate he was on was impacting his sleep, and were unclear whether a formal diagnosis of ADHD had been made. He also had a confirmed diagnosis of sleep apnea, and was very non-compliant with his CPAP. And his sleep hygiene was absolutely terrible. He had a large intake of caffeine during the day, probably contributing to his nocturia, which was also impacting his sleep. He was also on zopiclone for sleep, which was both not very effective and possibly contributing to his cognitive issues, sedation, and falls, especially when combined with his olanzapine.
He also presented with concerns about his memory and his attention. He described to me from his initial list a spaghetti incident where he left a pot of boiling water on the element and it completely boiled off, and this scared him. He had difficulty recalling even very recent medical appointments with specialists to me. And as we had ongoing issues with not receiving consult notes or records, this was particularly difficult to navigate. Well, I wondered about the role of his sleep apnea, his psychiatric symptoms, or polypharmacy. This was clearly concerning for a possible major neurocognitive disorder. After chart review, however, it was clear that these concerns had been extensively worked up previously. He had been seen by the memory clinic as part of our teaching practice, and he had a comprehensive geriatric assessment. Both times he had normal neuroimaging, normal labs. He had consistent MoCA cognitive testing of 26 out of 30 with deficits in delayed recall, but otherwise not meeting the criteria even for a minor cognitive impairment. Interestingly, the patient didn't actually remember these memory assessments. He did recall once being told not to drive for a brief period of time before his first memory assessment, but otherwise he presented the memory concerns as if they were a new issue. A consistent thread throughout these was that polypharmacy, in addition to untreated sleep apnea and a severe mood disorder, could be causing these cognitive symptoms.
And next, we wanted to talk about his mood. So throughout this whole process, the main issue that he wanted to address was his persistent, very low mood. And as we mentioned, his chart had several mental health diagnoses, but it wasn't always very clear whether these had been formally assessed. For example, bipolar 2 was listed in his chart, and a review of his previous medications suggested that he had been treated for this in the past. But this diagnosis was made based on one possible hypomanic episode over 30 years ago, and he hadn't had another episode since. He was also being treated, like I mentioned, with long-acting methylphenidate and had tried other stimulants previously. But we later learned that this was initially started for a lack of motivation and fatigue. But many of his subsequent providers understandably assumed that he had a diagnosis of ADHD because he was on these medications.
Importantly, working with this patient initially, we didn't have records of what psychiatric medications had been tried previously. It actually took many hours of combing through the piecemeal notes that I was able to get access to start to compile a list of what had been tried previously. During this time, we had the incredible benefit of a Jerry MedRisk consultation here in Ontario that did as comprehensive a medication history as possible, given his fragmented records and his poor memory. It was often hard to decipher, though, what was meant in some of these records. So, for example, one of the plans from his previous psychiatrist was reduce methylphenidate to 36, then increase it to 72 milligrams, then discontinue brexpiprazole for 5 days and then resume it. And it was difficult to know what to infer from these plans.
We also learned that very appropriately, he had been re-referred to psychiatry by the family doctor that I took the practice over from the year before. But when we wrote inquiring when he might be seen, we received this response essentially stating that they had tried everything for him. They didn't feel that further pharmacological strategies were going to be beneficial, and the referral had been declined. When we referred to a newer interventional psychiatry team, they responded saying his medications needed to be optimized before they would consider interventional treatments. So it was up to us to figure out what the next steps were and where to go from here.
So starting in 2022, we began to meet regularly. At each appointment, he would bring a new list of concerns and updates. It was an ongoing effort to stay up to date with his care. I spent hours, realistically, doing issue-based chart reviews and tidying up his chart. But we did begin to seek expert help. I wrote to his existing specialist frequently, and I would often ask his pharmacist to fax me his most recent blister pack list, just so I could keep up to date with med changes from other prescribers. Developing a rapport with the patient and his wife, though, allowed us to navigate this process together, and we began to slowly start the process of deprescribing. We were able to initially stop zopiclone by focusing on sleep hygiene, and we were able to reduce his methylphenidate dose.
We were also able to get input from a few specialists, but we were tasked with implementing and monitoring the patient during these changes. So as you can see, there's some overlap in the recommendations that were made, but also some contradicting advice. So across the board, there was a recommendation to increase the patient's vortioxetine and stop his zopiclone, which we were able to do. Interventional psychiatry and the geriatric MedRisk team also both advised discontinuing one of his antipsychotics and leaving the other on board. Geriatric psychiatry then advised stopping both antipsychotics. And there was also a consistent recommendation to have a formal ADHD assessment done. With this, we opted to taper his olanzapine, but unfortunately his mood worsened and we couldn't discontinue this as planned. We tried increasing the brexpiprazole, but his tremor worsened, so we were unable to continue with this. And in the end, we ended up stopping the brexpiprazole, but continued the olanzapine.
By April 2023, we had been able to stop one of his 2 antipsychotics, but he was still very bothered by persistent depression and tremor. We opted to e-consult a neurologist using the videos I showed to ask whether it's possible to distinguish idiopathic Parkinson's disease from a drug-induced Parkinsonism without fully tapering his antipsychotics. The neurologist thought his symptoms were most consistent with a drug-induced Parkinsonism and possibly an underlying essential tremor as well. They recommended a trial of propranolol and to consider adding additional medications to address the drug-induced symptoms of the antipsychotic. We wrote back to ask if this was a drug-induced Parkinsonism, could we stop his levodopa? And we also asked if there was anything we could do to change the olanzapine. We did a trial of the propranolol, which the patient thought made some improvement to his tremor. Both the neurologist and our in-clinic pharmacy team made the suggestion that we cross-taper olanzapine to quetiapine because it had a reduced risk of EPS symptoms, and it had the added benefit of a reduced hepatic burden in the context of his compensated cirrhosis. So we did this cross taper and he did well during the transition. Initially, they felt like both his mood and tremor were improved, but after a few months, he was still experiencing significant low mood. During one of my many chart reviews, I saw that in the context of his mood and weight gain, he had been started on levothyroxine after a single elevated TSH reading of 5, and no T3, T4 testing was ever done. So we opted to trial the patient off this medication, and luckily all the subsequent TSHs have been normal. More than any medication changes during this time, I felt like the most benefit to the patient's mood seemed to be from having regular appointments, developing that therapeutic alliance between us, and also his work with our incredible occupational therapist who focused on behavioral activation strategies for his low mood.
So Dr. Marwood completed her residency in 2023, but thankfully had put in an immense amount of work, if you can't already tell, for this patient. Since then, unfortunately, his mood has remained a significant concern. We did trial a higher dose of the quetiapine, but he felt that it worsened his tremor, so we were unable to up-titrate this. He was seen by the geriatric psychiatry team, who actually did not make any medication or major medication changes, but they did add trazodone for sleep, which he has found to be a bit helpful. His mood is still quite poor, and he's actually waiting to be seen by neuropsychiatry, which is scheduled for the middle of July. His tremor, though, has actually improved significantly, and it's now rarely, if ever, brought up at follow-up visits. I actually brought it up to take the video that you'll see in the coming slides. And he was seen by the Movement Disorders Clinic and diagnosed with an underlying essential tremor. So his carbidopa-levodopa was tapered and stopped, but he does continue on propranolol. So we can see in this most recent video that I apologize for the quality of, his finger to nose test has improved quite a bit. Before he was completely missing the mark and just passing by the finger. And on his rapid alternating movements, this does seem to be a lot more coordinated as well. And functionally, which I think is most important, he notes that the tremor is having less of an impact on his day-to-day activity. So we did get some success here. In terms of lessons learned, I think there's a lot here, but I'll try to distill it down into a few things. I think one of the biggest things as new staff, it was really important to have the confidence to question some of these existing diagnoses and determine whether some of these legacy medications were still appropriate and indicated. As family physicians expected to implement recommendations from various specialists and maintain continuity amidst a lot of medical complexity, that can be quite daunting. But I think what I really learned here is putting in the time to update the patient chart, whether it's myself or my very competent resident, can certainly, you're saving yourself, your future self time going forward. I think this case also really highlighted the importance of continuity of care and giving some historical perspective and context to patient symptoms that might be raised as new and not raising alarm bells every time something is brought up, and minimizing or trying to minimize unnecessary over investigation. So now we really try to summarize visits at the end and focus on indication-based prescribing.
For me, the lesson learned was really about how polypharmacy can arise from diagnostic uncertainty. Fragmented, incomplete health records, the involvement of multiple prescribers can all contribute to this medication overload. And while I was initially really aghast meeting this patient, I think this process for me was really humbling. When I think back to where we started, it's now easier for me to understand how this situation could possibly come about. During this process, I tried to fulfill the remit of family medicine to provide an anchor of continuity in this sea of complexity. I will admit, though, it often felt like swimming upstream in our siloed healthcare system, but it was also the most rewarding work of my entire residency. It was also an exercise in relational medicine. The patient, I think, benefited the most from having a consistent medical team that he knew were dedicated to working holistically with him. So in conclusion, we hope you see that a lot can be gained from one or two clinicians digging deep and taking the reins. We were able to stop or lower the doses of many medications, but we acknowledge that other medications were added throughout this time by other prescribers. Deprescribing in the face of active medical and psychiatric complexity, particularly with difficulty accessing timely, appropriate, or collaborative specialist services, is really an imperfect process. So the definition of success in this case might be leaving medical records that are more accurate and up to date, with clarifications on diagnoses, historical medication trials, areas of ongoing uncertainty and investigation. It might also be developing a therapeutic relationship with the patient. The issues are ongoing, as Dr. Henry explained, but the list is smaller and more familiar. This is a list that he gave me on one of my last days of residency. And I think we're now able to see more clearly through the complexity. For example, when a patient starts magnesium and then develops diarrhea, we're able to have the historical perspective to appropriately respond instead of react, and sometimes to deprescribe instead of prescribe.
Marrison and Shayna, thank you very much. That, as the audience can imagine, that was an unbelievably difficult case to present in the time that you did. And the audience may not have noticed that you were both trained in outside of Canada, so you're a nice testament to international medical graduates' contribution to Canadian healthcare. I think I see one of my former McGill 1978 medical school classmates is attending today, and I suspect he would agree with me in saying it's a breath of fresh air to an experienced physician to see people willing to take on the challenges in the way you have in this case, and for much of the audience. Now, there are quite a few questions. I just want to make one comment first, which is that when you mention a consultant told you that medications needed to be optimized, that to me is an absolute red 3-alarm bell for me when a doctor says they should be optimized, because in our experience in the Therapeutics Initiative, we would have to look a very long ways before we know what the optimum treatment, optimum dose of any drug is other than the lowest possible dose. And particularly for drugs used in psychiatry, if anyone in the audience has some good evidence of a clear dose response that's beneficial more than harmful, I would love to know it. I'd prefer to have that not just in the chat, but by email. So some of the questions are from Joanna McCabe. Could all of his drugs be causing his mood symptoms?
Yeah, and I think that's certainly something that we're thinking of. I think the tricky thing was anytime we tried to decrease any of his psychiatric medications, his mood would worsen, and his mood right now is actually quite poor. So I'm curious to see what the neuropsychiatry team says. But yes, Marrison and I actually, in working on this presentation, that's something that came up. Like, we both were kind of like, we wish we could just take him off all of these meds and see how he does. But in reality, I think that would be really hard to get buy-in from him.
I think there's some other comments in the chat that are very interesting. We may be able to come back to emphasizing some of them in a minute. Another issue I just picked up on was somebody asked about, or you mentioned vortioxetine, and much of the audience might not be aware that in Canada, you can now learn why Health Canada has recommended, has licensed a new drug, a so-called notice of compliance. And the summary basis of decision is what that is called. It's rather awkward to find on the Health Canada website, but for those who are interested, if you, for example, look up the summary basis of decision for the licensing of vortioxetine, you'll find that in at least one randomized clinical trial, vortioxetine was better for depression than placebo. If you read a bit further, you'll see, if I remember correctly, there were about 6 trials in which it was not better than placebo. You could really wonder why we needed vortioxetine if you read only the summary basis of decision. But if you go further and ask, were there comparative trials? In fact, there were with other licensed antidepressants, and in both of those trials, vortioxetine lost out. In one case to venlafaxine, that personally I would consider an awful drug, and in another case to duloxetine, that personally I would consider a nearly useless drug. So when you see recommendations for vortioxetine, it always makes me wonder, do the people who are making those recommendations have any idea what they're doing? But let's come back to questions. One question was, at what dose of brexpiprazole did this man's tremor worsen?
I believe he was on 1 milligram when we started, and the recommendation from our psychiatry colleagues was to, like, I'm going to use the word optimize again, but increase to a more maximum dose one and decrease the other. So when we went up to 2 milligrams, his tremor was significantly worse.
I thought there's a very interesting question from a clinical pharmacist also in Hamilton. Does this man have hepatic encephalopathy?
I thought that was a good question too. I saw that in the chat. I mean, he's very closely followed by hepatology, who every time he comes in, he definitely brings up most of his issues. So even at his specialist appointments, he'll raise these issues to them. So my sense is that I haven't been worried about that, but I think it's something that's worth kind of reconsidering. But his liver disease has been fairly stable amidst all of this complexity. So it's a very good thought, though. It was a very good question.
Yeah,
And
it's
it was raised by the Jerry Medrisk team. They really looked through his med list with the hepatic risk lens and recommended hepatic dosing for some of the medications.
It's an important question because I may be a bit out of date, but neurologists, including movement disorder specialists, do not appreciate that liver failure itself can be a cause of Parkinsonian symptoms. I learned that from a man with a horrendous situation of non-alcoholic liver disease, fatty liver, hepatic encephalopathy, and his wife insisted when the admitting team in Vancouver General Hospital said he's been a heavy drinker, his wife butted in and said, absolutely not, he's been a teetotaler all his life. What are you talking about? It raised my curiosity enough, and I had a very good medical student working with me, and I asked her to look up, does liver disease ever cause Parkinsonism? She found, for those of you interested, she found a report, I think from approximately 2005, from a group, liver disease group in Lausanne, Switzerland. Shouldn't be too hard to find that, Parkinsonism and liver disease, who had reported a case series and shown it clearly, liver disease itself can clearly cause Parkinsonian symptoms. And the Vancouver very experienced movement disorder specialist was astounded to learn that. When we asked him, would you object if we took away the levodopa, which may be causing problems? He said, no, that's okay. Well, he's in hospital, it's fine, but he was completely unaware of this. So it's something that it's probably almost impossible to prove if you've got somebody other than by trying to improve the liver disease and get rid of anything you can.
I'll just have a peek through the chat. I did want to add about the previous question that it's sort of the good news, but there's a downside that by the time he saw the movement disorder neurologist, his Parkinsonism symptoms had improved. So it's, he didn't see them until after I finished my training, but I was really interested to hear from Dr. Henry that like his tremor had improved so much by the time he saw them that they were able to kind of see more, there is an underlying essential tremor. But I wonder how much the deprescribing work we did and getting off those antipsychotics got rid of the Parkinsonism before he was seen by the specialist clinic.
Yeah, there are a number of comments.
I like this one comment about what about propranolol contributing to low mood and fatigue, because I just had a conversation with him about that the last time I saw him. Yeah, it's definitely a thought, but he really feels like it's helping with his tremors, so wants to keep it on board. Because I think this is another tricky thing, but I think important thing to remember is that at the end of the day, like, this is about shared decision making, right? So we can make recommendations and say this is what we think might be contributing, but I think it's really important to have him be involved in these decisions as well, and that was one that he wanted to keep on board.
The same discussion I had with him when we started the propranolol was, informing him of the risks, and at that time, he said a similar thing, which is that, the tremor was really functionally impairing him and he wanted to try to address it, and he was willing to risk possible mood side effects.
There's another comment from Dr. Rashmi Chadha, who's a specialist in addiction medicine, that some of the symptoms going back far enough, including the alleged bipolar episode, might relate to undisclosed or undiagnosed addiction issues. Maybe what we should do is warn you, you're at high risk now of having people contact you and wanting to be your patients, the two of you. I'm afraid, but hopefully you're helping to teach some of your skills and particularly your attitudes to your colleagues. Obviously so, and I just want to thank you for another wonderful presentation. I think the audience can begin to understand. Marrison has been working on this for 3 months with assistance from her mentor, Shayna. I am going to invite people because I think Shawn was able to stay for a while. If you want to come back to questions we didn't resolve before, there were two that we certainly didn't touch on. One was, do you want to comment on whether tryptophan has any effects in depression or any other issue, the essential amino acid tryptophan that's supposedly very high in turkey meat, for example? Or is it better to eat lots of turkey?
A good question. I think there's a great systematic review that looks at kind of the serotonin theory of depression. And they did, after reading that review, I looked at some of the studies that they reference. I think there's a few studies on tryptophan diets and the implications in depression. I can't comment off the top of my head, but I think that's a great reference if someone wants to learn more about. I can dig that up and send that to you, Tom, and you can share that for sure.
Thank you. Another question was from a hypnotherapist who wanted to know more detail. What non-pharmacological techniques, for example, breathing techniques, do you recommend?
Some of the breathing techniques I coach my patients on, there's 2 specific methods. One is called the 4-7-8 method. It's popularized by Dr. Andrew Weil, who's a physician in the States. He's also a functional medicine physician as well. But essentially the methodology is you inhale through the nose and hold it's a 4-second inhale. It doesn't have to be exactly 4 Mississippis, but the idea is you inhale for 4, then you hold for 7, and you then exhale for 8. So doing that about 4 repetitions, I use it personally as well. Sometimes, like before this presentation, it's just a method to kind of reduce a little bit of anxiety and calm the nervous system down. The other technique I like to employ is something called a double inhale and exhale. So a double inhale is when you breathe in through the nose and try and get as much air in as you can. And right at the end of that inhalation, you do a second inhale, and then you hold and slowly physiologically sigh and exhale through the mouth. And those are just techniques that I employ in my own experience with anxiety here and there. But I find that's a good way to kind of take the edge off and bring sort of, they say if you want to sort of move the mind, you move a muscle or move the breath. So it's a good way to kind of focus and get kind of out of the head and back into the body to kind of tackle any sort of panic or any anxiety in the present moment. In regards to the meditation and mindfulness-based stress reduction, there's a lot of resources available to everyone out there. I prefer using a specific app. It's called Waking Up by Sam Harris, PhD neuroscientist out of Stanford. It's a great app. It's free. That's one of the reasons why I like it. If you just email them, go on their website, they offer scholarship programs to anyone and everyone. And I've been using that app since its inception, or since it first came out, I think in 2017. So I've stuck with it, and it's a practice I kind of believe in terms of helping with my own sort of struggles with anxiety. But it's really a rich resource for anyone looking to learn more about mindfulness-based training, philosophy, and it's got a really incredible, rich library of resources on that front.
Shawn, I suspect I'm not the only older or experienced physician who's concluded that often the most useful thing I offered to patients was friendliness and follow-up. Do you have any opinion over whether some of what you're doing is more just being available to patients and friendly to them?
Yeah, absolutely, Tom. It's really about building trust and building relationships. A lot of times, in my experience, I catch a lot of patients on their journey in mental health. And, when they're refilling a prescription that's, 2 or 3 years old or sometimes a decade plus, and they've never really had that conversation with their primary physician or prescribing physician in terms of like, where are they at currently with their mental health? So a lot of it is just kind of extending an arm and an olive branch to say, hey, let's talk and discuss kind of where you're at in your journey with mental health. And a lot of times these medications are kind of set, it's kind of the set and forget model, like you're prescribed these drugs and off you go. And when you do your follow-up, like, you know, as we just saw with the previous case with the Marrison and Shayna, like you only have such limited time to review so many issues. It can be difficult to kind of bring up that conversation of deprescribing and tapering. So a lot of the work I do is it is definitely an experience in making sure patients understand that they do have sort of someone that they can rely on to discuss kind of these issues that they're going through, or discuss when they're ready to come off the medicine. And that's kind of the approach I've taken. And it's really just an initiative I started off as kind of a passion project, but it's growing significantly. I think it does answer that question. To answer your question, Tom, it is a lot of it kind of being rooted in providing patients with, you know, an open arm to, in case they have any issues or that they're dealing with, to kind of, you know, lean on the healthcare providers that are available to them.
I'd just like to thank everyone for joining, and particularly thank Dr. Shawn Gill, Dr. Marrison Marwood, Dr. Shayna Henry for presenting. I'd like to just remind the audience, if you're interested to make a presentation in this series, we do have opportunities. The way to get started is to send me an email at tom.perry@ubc.ca.